It's been in the news all over Canada and different parts of the world is that our nursing home situation. So one of the things that we're going to talk about tonight is that Emma, with the help of Dr. Phil McGarry and Dr. Joanna Hill, who both are senior physicians who now work as medical directors in nursing homes in the Niagara area. And as well as being fantastic doctors, they really look after themselves, and they're good colleagues and good friends. So I'm really looking forward to learning more about what happens in the last couple of years of people's lives when they no longer can look after themselves. And also, too, will be a plea is that, and we're going to talk about this in a little bit more detail as well, is that how to prevent yourself from aging too rapidly. So lots to talk about. Lots of emotion and lots of good science and lots of information. So I want to thank Emma for putting this together, and I'll let her take over. And I'm really looking forward to this wonderful presentation.
Yeah, absolutely. Hi, everyone. Thank you for that introduction, Dr. Kernew. So the next slide, we're just going to table of contents of what we're going to cover tonight. First of all, we're going to start off with an introduction. Then we're going to go into a little bit about the different types of care that is available in Ontario, and then specifically taking a look at long-term care facilities in detail. And at any point, if there's any questions, feel free to ask in the chat. I believe Stuart will be monitoring that. So as a quick introduction, please meet Dr. McGarry and Dr. Hill. So they've actually joined us previously discussing their experiences as from the physician as well as the patient perspective in navigating heart disease. And so they both trained at the Medical School of Western Ontario, where they first met for the first time. And now they are semi-retired and taking care of patients in retirement homes and long-term care homes. And so I think something that is really wonderful about them, if you, Dr. McGarry and Dr. Hill, you would like to talk a little bit more about, this is their life. There's some snapshots of their life. They are very active people. They eat very well, and they are very loved by their family. Dr. McGarry, Dr. Hill, would you like to add anything to your introduction?
Well, I think we were lucky to meet each other. And yeah, we've always enjoyed exercise, thanks to Joanna. We've always been very active, and we've raised 3 children. We've had 2 busy practices. We're semi-retired now. We do long-term care. We like to ski, although we ski in New York State. We haven't been able to get there this year, but we like to travel. You can see Mount Fuji in the background when we were in Japan. And that we have 6.5 grandchildren. We're getting a new one in May, and they're very close to our hearts. And we enjoy life with Greg Kernew and his team. We've changed our diets. We're full vegan now, and actually we really enjoy our food. And I really think it's helped me. I'm the one with the heart disease. My partner, Joanna, doesn't, but she's so supportive. And I know that the diet and the medication and exercise is contributing to our hopefully healthy longevity. We can avoid getting into long-term care until we're really old. Of course, you see all these old people getting into long-term care, and I say it's Greg's fault for making us live too long. And yeah, that's, go ahead, Emma.
So one of the reasons to live long, and you mentioned plant-based eating. So I'm having a bowl of vegetable soup tonight, and I encourage people there is that while during the webinar, or is to just get out some little bit of food over here and enjoy, learn, and ask lots of questions. And thank you.
Yeah, one of the meals you'll see, if you just go back, Emma, is what it was easy to be vegan in Japan, and I think, is that a Japanese meal there, Joanna?
I think so.
I think so, eh? And it was wonderful. I'd highly recommend visiting Japan. It's a wonderful time.
Right, yeah, so a little bit about this webinar. Thank you so much, Dr. Hill, Dr. McGarry, for that introduction, is to give you some insight into the long-term care facilities in Ontario. So we really encourage you to, talk to others, talk to us, do your own research, and ask us questions. So I believe it's both in the YouTube as well as the webinar directly in the WebEx that Stuart will be monitoring. So right now we're just going to start off with a little bit more about Canada and some facts and some statistics that we were able to find. So Canada in numbers, we found that one study conducted in 2015 found that the average person generates $14,000 in healthcare costs during the last 30 days of their life. So in this graph over here, you can see in green the total cost, and you can see how it starts spikely right around 31 to 60 and 0 to 30 days before they pass away, as well as the total acute care costs in red. And so this study also found that 0.67% of the population consumed 10% of Ontario's total healthcare budget of $4.7 billion per year. And another important thing to keep in mind is Canada's changing demographics. So on the chart to the left, we can see in light blue the number of people in millions who are 65 years and older. In dark blue, we can see the number of people who are in millions who are between 0 and 14 years of age. And you can see right around 2016, it was something really unique that happened. For the first time in census history, the number of people who were 65 years and older actually surpassed the number of people in Canada who were between the ages of 0 and 14. And as you can see, by 2040, it's projected that there's going to be 10.7 million people 65 years and older versus only around 8 million in the younger side. So it's definitely something that we have to consider, and looking forward, how we're going to navigate the new healthcare system and seeing how we can make sure that we allocate the resources effectively to account for these differences. Dr. McGarry, Dr. Hill, do you have any pieces you want to add to this graph? Right, so the next section, we're going to be talking a little bit more about the different types of care in Ontario. Specifically, we're going to be focusing on these 5 types of care. And so hopefully we will give you an overview of what's going on in Ontario. This is not to serve as your only source of information, so we do encourage you to go look on government websites to learn more about this. So starting off with acute hospital care. And our acute hospital care is really intended for intensive level of care for acute, also known as short-term problems. So typically they occur in acute intensive hospitals, so directly in the hospitals, and they will likely start the investigation, finish and figure out what's wrong with you, what's your symptoms, and then start the treatment plan, but you will be discharged as soon as possible. In terms of the selection process, it's just available to everyone with OHIP, and in terms of out-of-pocket costs, everything's covered if you do have OHIP except for any preferred accommodation. So for example, if you would like a private or a semi-private room as opposed to rooming with other people. The next one we'll talk about is a little bit more about home care. And so home care is just care for people who require care at their home, community, or school. And so there's 2 different versions of it. If you see at the top left corner, there is a public version covered by OHIP. There's also private home care available, and those typically range between $55 to $80 an hour. So it is quite a steep pricing, and that would be done through hiring, like, for example, personal support workers through different agencies. And so if you are going through the public route, the selection process is typically done by LHIN, who decides the eligibility as well as the level and length of care that this person receives. And it's typically offered through community care access centers. And if you can see at the bottom right corner, those are the different types of home care that they offer. Dr. Hill, Dr. McGarry, anything to add to this slide?
Just that LHIN is the new term for the CCAC. They changed their name, and they have divisions within the LHIN. They have like their home care division, the palliative care division, the nursing home divisions. So that's the terms can be really confusing for the public. But it's used to be called home care, then it was called CCAC. Now it's called the LHIN. And I'd say for the most part that it's limited number of hours you can get through the public system. And if you need more care, then this wouldn't be the place to go, unless you had the resources to purchase. It'd be quite expensive, can't it, Tim?
Yeah, $55 to $80 an hour is quite a lot of money. Sure. Right. And so the next section is complex continuing care, and I think I'll hand it over to Dr. McGarry because you do work with people as part of the type of care.
Complex continuing care is when you'd be transferred to, say, it's usually a hospital level, and you've been diagnosed in acute care. A treatment plan's been organized, but you need extensive physiotherapy, maybe a long-term antibiotic intravenously, and you're not well enough to go home, and so you're transferred to a chronic care hospital. Most hospitals have a wing that would be complex continuing care. Some hospitals just specialize in that. Like in Niagara here, there's the Shaver, Hotel du Shaver, Port Colborne Hospital are our chronic care hospitals here. And some hospitals like Niagara Falls and Welland have wings. I'm sure in Hamilton, I think Shadough's a complex continuing care as well. And there, you do pay out-of-pocket expenses for, they call that like room and board. They pay for everything except for they want you to pay for your own meals and your room. And I think it's, as Emma's got there, it's about almost $1,900 a month. And that's why you'd be in complex continuing care. When you don't require their services anymore, then we can go to the next step. Hopefully you go home. But what are the other options if you're not well enough to go that route? Home.
So some of the other options are retirement homes and long-term care homes. So we'll look at retirement homes first. And so retirement homes are generally for seniors who can live mostly independently, so with little to no help required, who can also pay for the cost of living in a retirement home. So the selection process is directly to the each retirement home. It's not done through the government. So sometimes retirement homes may have to decide that they can't provide the level of care you need, or certain things that you don't like about this retirement home that you prefer about another. So that's kind of how the selection process works. And the care offered is minimal and to certain degrees, depending again on the type of retirement home and what they offer. And the out-of-pocket costs can range anywhere from $1,500 to $6,000 a month. And so taking a look at the bigger picture, there are 756 licensed retirement homes in Ontario, and they are all privately owned. And so these are some of the regulations that they are covered under. Dr. Hill, would you like to add any more insights about the retirement home?
Sure. I work at a well-known retirement home in Niagara Falls, and its rules and regulations and legislation is different than long-term care. So that's why there's quite a range of what can be purchased through your retirement home. So residents that are looking towards a retirement home, a lot of them would just want like a small apartment or a room and have their meals provided, and then the home would give recreational activities and this type of thing. Now, the home that I work in, we offer a lot more in the way of medical treatment, and there's a nurse on duty 24 hours a day. We dispense medication. The nurses will do nursing assessments for me. So so that's why there's a big price difference from $1,500 to $6,000. And obviously they're for profit too. So you want to carefully check out, any retirement home that you're looking to go into. Another problem that I have with the retirement home is that sometimes patients are in one retirement home, but after a couple of years, they need more supervision and more medical care, but they're not to the point yet where they want to go into a long-term care facility. So they'll often move from one retirement home to, for instance, a retirement home where I work, where you have 24-hour-a-day nursing care. So it's quite different than a nursing home, because a nursing home is very regulated. And in every nursing home, certain standards have to be met, but that's not true for retirement homes.
Is it true, Dr. Hill, that would you say that they don't even though you purchase help, the quality of the help may be quite variable from retirement home to retirement home.
Right. So the quality of the care could be quite different too. And so, for instance, the administrator at the retirement home where I do work is a fully trained registered nurse, and she's an excellent geriatric nurse. Plus, she's the administrator of the home. So that's very important, and because as these residents age, obviously they're going to have more and more chronic medical conditions as they refer to elderly people. The average age at the retirement home where I work is 92. And that is actually older than at a long-term care facility where I work. And it's, so there's many reasons why, but I'm just pointing that out to you. So if you're dealing with 92-year-old patients, you can imagine a lot of them are going to need a lot of nursing care and good management.
And some of them would have listened to Dr. Kerner when they were younger, and they're much more, some of them are very functional too, aren't
Some
they?
of them are very functional at night. The average age is 92. I've got somebody in the home right now that's over 100.
But they don't want to live alone.
No, it would not be safe for them to live alone because they're prone to falls. They could have like angina attacks, and they need like a nurse that's available to them. And plus, the families need that reassurance, especially because families often live in Toronto, or they don't all live in Niagara Falls, right near their loved ones. So, the resident is quite reliant on the staff at the home because their relatives live elsewhere, and the relatives are maybe still working or whatever. So, yeah, there's a lot of decisions to be made about retirement homes if you're looking for that type of care.
So if someone's going to be thinking that they need some extra help and they want to go to a retirement home, are you guys going to give some suggestions on how to evaluate? At one time you see these commercials, come have lunch with us, so I'd be curious from your perspective if someone in your family is require retirement home settings and what to do and what to look at. I once went to this really good webinar, actually a conference where we're seeing in person where they're talking about how to age well, and we're going to talk about that too as well. But if you look around, one of the things I remember is that look around where you live, look around what's important to you. So, for instance, if you like walking outside with green grass and trees, pick a retirement home that has that setting, and look at the rooms of your house. And the ones that, because most time when you go to a place, you're going to have maybe one room. What are you going to take with you? And some of the things there. So I'd be curious but how do you evaluate the medical aspects as well and things? So give some pointers. How should people think about, choosing?
Well, I think
you had to do it for your mother.
Yeah, I think what you have to do is remember we're fully functional people, and we can make our own decisions, and we can look after ourselves. But usually when you need to go to a retirement facility, you're looking at things in a different perspective. So oftentimes you're maybe only in one room, but you really don't want to be walking like 50 feet to the bathroom, considering that often you have to go use the bathroom more often, like if you're 85 or 90, so you don't want to be walking 50 feet every time you want to go to the bathroom. So you want something that's reasonable. And so I'm saying, like, look at it from a perspective of an older patient. Like, what would they want? So often, like, meals and food are important things in their life, because not only is it food and nutrition, but it's often a social time too, except not during COVID. But usually you would eat with like 3 other people, maybe at your table. So you would want to make sure that maybe culturally or ethnically there were people that you would get along with or whatever. I noticed that the first Korean long-term care home, I think, is going to be in. It has been. It's a long-term care, and it's just for Korean people. So that there is a little bit of a cultural, ethnic thing to some of these homes. So you want to make sure that you're comfortable with that. I think another thing is you want to know what the layout is. Like some of these in Toronto, these homes, they're like 13 stories high, so you have to go up and down on elevators and things. Whereas in smaller cities, we don't have to have so much high rise, and so it's easier to get a 1 or 2 story building, and that allows you to probably get outside without as much hassle as having to take an elevator. I think another thing is like what activities are offered. So you want something that's reasonable. So you want like a recreational person that's going to give reasonable exercise programs or health programs that's appropriate for 80 or 90-year-olds. You don't want it too much, and you don't want them not giving you any exercise type programs. They usually take you on outings, so that is good because they often go shopping. So that gives residents some independence to go shopping and take their money and buy what they want. They often have little refrigerators in the room, so they can buy like snacks and things to refrigerate and put in their room. So that's kind of nice because that personalizes things for you. I think depending on your medical conditions and your age, you would want to know how much nursing help is available, and if you need more help, you could purchase it and how much that would cost. So, these are all important. Luckily, at my seniors residence, we try to keep people, if they've lived in our residence for some time, we try to keep them in that residence up until their death, including giving them palliative care and everything, unless there's problems we can't cope with. So that would be like behavioral problems, because we're not allowed to lock the doors. We're not allowed to do like certain safety issues, because sometimes older people, they get days and nights mixed up and they'll start wandering out in the middle of the night. That's very dangerous. So we can't lock the door, so they always have to be free to come and go. So I think there's many factors to look in. Food is good, but you have to make sure that it's food that's appropriate for older people, because older people, they tend to, their tastes have changed somewhat. Unfortunately, and chewing too, they're having usually some dental problems and that type of thing, some swallowing problems. Swallowing difficulties is very common too.
Culturally appropriate.
Yeah. So I think those are some basic things. My home, it offers parking. So if you drive, we have designating parking spots for you. But not too many patients drive, but that's okay. And
scooters, are there scooter parking?
No scooter parking, but we have a park right across the street, so that's good for the ones that want to walk to the park. That's very good. We got a hair salon for those that want to get their hair done. We have lots of arts and crafts. We have a lot of music programs, but a lot of this has had to stop because of COVID, but we bring in bands at least once a week, and we have music programs.
Non-COVID times, do they have fun?
Yeah, a lot of them have fun. They enjoy their life there, and a lot of older people understand that they could be a burden to their family. So a lot of them with insight don't want to burden their family. So they want to know that they're in a safe place and that they're going to be looked after without their family having to look after their every requirement many times a week. Also, some retirement homes can handle dementia, and some would have difficulties handling dementia, and especially advanced dementia. So that's important too.
Yeah, thank you for that insight. And we will talk a little bit later too about choosing long-term care homes, and that would definitely apply to retirement homes as well. So in terms of differences for long-term care homes specifically, we've been calling the term long-term care facilities, long-term care homes, as well as nursing homes are fairly interchangeable. We've moved away from calling them nursing homes and more so long-term care homes or long-term care facilities. And so long-term care facilities are typically for people who require 24-hour nursing and personal care. And so, needing help with assistance with daily living and monitoring to make sure that they are being safe and therefore their well-being as well. In terms of the selection process, it is highly selective. So people apply through the local government, and the care offered is intensive. There's nursing as well as personal care, drug and medical as well. Out-of-pocket costs are only for accommodations. So, for example, the food and the rent. And they range anywhere between around $1,900 up to $2,700, depending on, like if you would like a basic versus a private version of it. And so these rates are set by the Ministry of Long-Term Care and are standard across all homes in Ontario. So there are 626 long-term care facilities in Ontario at the moment. And something that I personally found very interesting was that the majority of it are private homes, privately owned. So about 16% is public, 57%, so the majority, is private for-profit, and then 27% is private not-for-profit. And so in terms of regulations, it's very different than the retirement homes. They are highly regulated, especially under Long-Term Care Homes Act of 2007. So I will go to the next page, but feel free to discuss anything in terms of long-term care facilities. Dr. Hill and Dr. McGarry, if you would like to add anything about that?
That's very accurate. I think you just continue on, and if we get any questions, we can highlight it.
Okay, sounds good. So once again, retirement homes versus long-term care facilities, these are some of the main differences in terms of population, selection process, the cost, as well as regulations. So for retirement homes, the population of people who live there are mostly independent. Again, like Dr. Hill highlighted, it differs a lot between retirement homes. For long-term care facilities, there typically more intensive care is needed. The selection process for retirement homes is application-based, compared to long-term care facilities that is usually highly regulated by the government, and there's a certain process that one has to follow. For retirement homes, the cost is basically everything, as well as any upgrades. And I think that's what Dr. Hill touched on, like the nursing care. If you need extra nursing care, how much would that cost? And so these are all different considerations. Compared to long-term care facilities, where it's really just the room and board, and maximum values are set at the government level to make sure that it's even across the board in Ontario. Regulations are quite different. So retirement homes are covered under the Retirement Homes Act of 2010, compared to the Long-Term Care Homes Act of 2007, which is arguably a lot more regulated. All right, and so the next,
Go ahead.
Can I just ask a question? So a question I have is that if, let's say you don't have finances, and you can't live at home, can you go to a retirement home that's funded or partially funded? How does that work? Or is that available or not?
There, regretfully, Greg, there are some slum landlords in Ontario, and there are some very, very basic retirement homes that are. There've been some here in Niagara, and I'm sure in every larger city in Canada, and they're basically like terrible, and they're the cheapest ones, and and that's where low-income people would have to go. Most of them are on a waiting list to get into long-term care. I know a couple of them have lost their license here in Niagara because of just poor conditions. As far as I think if a senior is with the old age security and CPP, I know with long-term care that they end up with about $150 extra a month if they take the basic accommodation. Retirement homes, if you pick a low-end one, you probably could have some extra money, but that would be no services. So it's a real gap, I think, in a real problem we have here.
Yeah, and I think that's why a lot of these patients that can't afford to go into a retirement home, once they're in an acute care hospital setting, and if they don't have the money to go to a retirement home, they stay in these
and they're too ill to go home.
And they're too ill to go home on their own. They keep staying in the complex chronic care,
or go into transition care,
or into transition care. But they're the people that we have to do something about that group of people, because they're not in the right area for themselves, and they're making it such that the beds are blocking up for the people that really do need that type of care. So that's a big problem. That's a huge problem.
It's a good point, Greg. And I should have, I did bring it up with Emma, but I didn't talk about transition care. And this came about a few years ago where there was a crisis in admitting people to long-term care. There were not enough beds, and a lot of people were either too ill to go to a retirement home, or they just didn't have the funding. So the government bought beds in different retirement homes around Ontario, and they put in, they paid for extra help, the government did, through the LHIN, and they put some of them very ill patients into these, I call them fake nursing homes, but they call them transition beds. And some of it's been a real disaster when we get these residents from these retirement transition beds. They can be very ill, and they didn't get blood work, they hadn't had medical care. Sometimes it works out well, but that's an area that needs to be improved.
It also reminds me is that we all have to think about how we're going to age and how to put resources for later in life, because you mentioned a lot of us have burdens on our family. So to me is that this is a reminder, A, to be healthy. Number two is to try to put money aside for the future, because we will need help, and I don't know how the government can afford to do everything it's supposed to do, and so right now is that so think about how you're going to age and how you're going to put money aside for the future.
Right. Well, we'll get into that a little later. Emma, why don't you go to the next slide? But keep in mind that transition care. If you hear that term, and if you don't
beware.
Beware. If you don't think your family is ready, speak up. I think you can say you refuse to let them go. We almost lost Joanna's father when we were away. They put him in transition care. It almost cost him his life.
And so for the next section, we're going to go a little bit deeper into the long-term care facilities. And then, hopefully we'll be able to touch on those topics a little bit more in depth. So this is an overview of the admissions process. So you can see at the top left corner in yellow is the application to the long-term care facility, or several. And this is a discussion that you would have with your family, with your LHIN, as well as your healthcare team, just to check which facilities fit your needs, which ones you would like to apply to. And by law, each long-term care facility that you apply to have 5 days to make a decision of either accepting or denying your request. In terms of denial, a written notice does have to be sent to the applicant, the placement coordinator, as well as the ministry. In the case that you are accepted, it is, I believe, more than likely that you will be placed on a wait list. And that wait list is determined by a MAPLE score. And this is just to see how in need of long-term care you are and your priority in ranking across all of the other people on the wait list. Once you are accepted, by law, they are required to have a 24-hour admission plan, and within 14 days, so within 2 weeks of your admission, An individualized full plan of care will be developed, and that will be a plan of care that is talked about with your family, with the person entering the long-term care facility to make sure that all of their plans and goals are met and their wishes are being met as well. And so something that came up in my conversation with Dr. Hill and Dr. McGarry is really the way that a lot of people are actually admitted into long-term care facilities. Oftentimes, of course, you can plan as best as you can apply to these places, but more often than not, it is likely a crisis that brings you into a long-term care facility. Dr. Hill and Dr. McGarry, could you expand on that a little bit more?
Well, most of the time it's a crisis that leads to admission. Often there'll be an acute injury on an elderly person, quite often a fall, they break their hip, they get their hip fixed. Like I said, the acute hospital will fix the problem after 3 or 4 days. They've done their fixing, but they're not able to walk. They have to learn how to walk again after a broken hip, and that takes weeks. And so quite often they're sent to complex continuing care. If they don't progress, or if the anesthesia has brought out their dementia, they're delirious, there's only so much time they can give them in complex care, then they'll apply to a nursing home. So usually a health crisis will precipitate admission to long-term care a good deal of the time, right, Joanna? Yeah. There's, I'd say maybe, 80% of the time? 80% of the time? 20% of the time maybe from they're planned and they come from home. Maybe their dementia has gotten progressive and the family resources have run out. That's quite common as well. But
sometimes it's also like they have a chronic condition and it hasn't been too bad. So, for instance, chronic obstructive pulmonary disease. So they managed okay, and then suddenly something happened, like they got pneumonia, and then their chronic obstructive pulmonary disease got worse, and they just can't manage anymore. So now they can't go home. They probably don't have the money to go to a retirement home. So now they're looking at long-term care.
They can't do the 4 METs anymore that Dr. Kernu taught us some weeks ago about you need 4 METs to do your activities of daily living. And just with their heart failure or their COPD, their pulmonary disease, they can't produce the METs and they can't live independently anymore. That's quite common too.
Very common.
And those ones can maybe do the planning where if it's gradual, but quite often acute injuries, catastrophic, or they'll go into heart failure. They had an MI, heart attack. I shouldn't use the jar. Heart attack, and then they've had heart damage. Their heart failure is worse, and they just can't produce the 4 METs anymore, and they need help with their activities of daily living. It's the newer homes have longer waiting lists. The older homes have longer waiting lists. Hopefully, we'll see all these older homes disappear in the next few years as the COVID crisis has pointed out their weaknesses in the downfall of these crowded homes. So there may be not the disparity that there is right now.
Absolutely. And speaking of planning, of course, there's only so much we can do, but it is important to, try your best to plan ahead. And it's difficult to, anticipate yourself ever having a crisis, but hopefully you have all your ducks in a row and know your plans and your wishes moving forward. The priority, of course, is still to stay as healthy for as long as possible, and that comes with eating well, staying fit and active, taking your medications, and working actively with your healthcare team to make sure that everything is working well for you and your current health status. And very importantly is to prevent falls. We'll touch on that in the next slide a little bit more. Another important point is to make plans for your living situation. So Dr. McGarry and Dr. Hill touched a lot on this. There is a lot to consider in terms of, where you want to live in the future, where you want to spend the rest of your days. Is it in a retirement home? What kind of retirement home, with who, etc. And something else that's also important to consider if you want to stay at home for as long as possible is to look around your house right now. Is it compatible with your disability? So in my talk with Dr. McGarry, he brought up the idea of if you have a lot of arthritis and you have, 2 flights of stairs in your house, is it friendly for your, moving around? Is it friendly for you when you grow older and your arthritis gets a little bit worse? And in another webinar, we will be touching on how specifically Dr. Hill and Dr. McGarry are in the process of making their house friendly and so that they can stay in it for as long as possible. And so for the next slide, I'm going to hand it over to Dr. Kearney to talk to you a little bit about frailty and falls in general.
This slide, it's actually, I find this slide very, very useful. The pictures are worth 1,000 words. So you can be very fit or you can be terminally ill. And we define terminally ill as you have a life expectancy less than 6 months, and people often go to palliative care. But people can, be very fit and active, or they become more fragile. And there's different ways of measuring fragility. I want everybody to take a look at this and decide what number are you. I'm a 1. Will I stay a 1 for how long? Some days I feel like I'm a number 9. But it's just something that we all have to be looking at that. And we're talking about how you decide where to go. And to me is that once you lose the ability to walk, once you had a fall, a lot of confidence is lost. And I can't remember the exact number, but once you fall and break a hip, you have an extremely high mortality. And so to me is that so you don't want to fall and break your hip. You want to use the proper tools. Do I need a walker? People say, a walker is it doesn't look good. You know what? A walker gives you independence. And you're tired, you just sit down on that seat with that. And to me is that people are using these motorized vehicles, which is nice, but when my time comes, I'm going to transition to a 5-speed walker that just kidding, that allows me to be mobile, and I want to be able to go outside. And one of the messages that I have is be skinny, lose weight, walk, be active, find some form of activity. Lots of sadness, lots of depression, lots of stress, but you know what? Every time I go outside and I do it in a safe way, I'm better off. And so think about how you can do that in your lives here. So I don't want to fret on how to define what category you are. You should look at the category you have and put the resources around you. Does anybody else want to comment on this slide? So when you have a person that comes to your place of residence, how do you define frailty? What do you look for? What do you do?
Well, the government has scales. They have different tools that they use. There's a ranking system. There's all sorts of different ranking systems, from your cognitive function, that's your mental thinking, your palliative scale, your activity scale, exercise scale, and they're standardized. And the government has all this reporting system that they have. This is in long-term care, mind you. It's called the MDS, the Minimal Data Set. And they have these RAP scores, and it's standardized across the province. So in long-term care, they're all kind of ranked with these different scales. In your retirement home, it would be different. Mm-hmm. And
well, I think that this scale is wonderful because it's telling you in layman's terms here of how these patients are doing. Now, in the long-term care, we give them numbers and we grade them, so we come up with a score. Also, the thing with that score is it also helps determine the funding that the government will give the home for that patient. So the long-term care home is very, very keen on doing proper what you would call frailty scales. But this is a very good frailty scale. And so, for instance, if a patient can dress themselves, that's a positive. If they can, toilet themselves, that's a positive. If they can feed themselves, that's a positive.
If they can't,
If they can't, then they get ranked on that, and so that puts their frailty scale like higher. Like I was looking here, your number 7, right there. It says completely dependent for personal care. So number 7 would be these people that need help for everything. They need help for dressing, for eating, for toileting, for everything. So I think it's pictorial, but the description is a very good frailty term. So I think it's a great thing. And then through the government, they've got it refined just a little bit more so.
Yeah, Dr. Curnew, I had a question for you. If people look at this and say, "Oh, I'm maybe a 3," is it possible for them to move up to a 2 or 1?
Yeah, I think there's always room for improvement. I'm a work in progress, and over time as we age, we lose our body reserves. So what I'm seeing over and over again, you have a body mass index of around 30. I'm just a little bit overweight. I'm going to start exercising next week. I'm going to wait till I retire. You're aging yourself faster. And then all of a sudden you get a pneumonia, and so you go from a 4 to a 6 or 7 very quickly. So that business about your horsepower, I like to I think people need to figure out what their fitness is and how to get fitter because once you're bedridden, you lose fitness very quickly. Your peak lung function is those 2 people on the right. You have peak lung function to around 25, then your lungs start to wear out. If you smoke, you accelerate that process. It just gets harder to be fit as you get older, but I think that's really important. So the message to me is, yes, you can move up the scale. And one of the things I see as well is that, let's say you're a 7. You're dependent on others. Someone has to push you around in the wheelchair most of the time. That means your life expectancy could be around 6 months. And then to say, well, I want now have a bypass surgery or an angioplasty or treatment for my cancer or for my kidney failure, you know what? It's not worth it. The amount of what you're going to put yourself through for a poor outcome and make yourself suffer more. So you have to really think about where you fit into this. So I want people to take a picture of this and think about and sort of how to keep yourself. The best way to keep fit is to keep fit and to really work about that weight. What we learned from COVID today is that you don't die because of COVID. You die because of the other medical problems you have. And about 30% of mortality is related to just your weight. High blood pressure, diabetes, and heart disease and lung disease explains over 2/3 to 70 to 80% of the mortality. I can't stop myself from aging, but I can make myself age healthier. So my plea to people is, don't wait till you're sick, because you've lost that reserve. Get on board very early on. So as you tell us, you have a couple years left of life when you're heading into that. When you make it to long-term care, so-called nursing home, make your quality of life as good as you can for as long as you can. So that's one way of looking at these sorts of things. And really think about in your mind, how do you move up the scale versus moving down the scale?
And Emma, I think that's a good segue for the talk on goals of care that people have too, that Dr. Curnew just brought up. This is something really important that we should all be talking about with our loved ones. And just my experience, even today, I had a 97-year-old demented lady who stopped eating and drinking, and the daughters couldn't decide what to do, and she wasn't my patient. I'm on call today, and I was really shocked that these daughters had never talked about it to themselves, or that the mother, when she was well, had never given her wishes. So Why don't you talk a bit about this, Emma?
Yeah, for sure. So I think, I've had this talk with especially my grandparents. They're also in their 70s and their 80s. And I think a lot of it comes down to right now they're doing well. They really want to have a say in how they age and how they, eventually pass on. And I think involving them in that decision making process is something that they really appreciate and something that over the time we would learn to talk more openly about. So, of course, this is a difficult conversation to have, but it is one that's very important, and especially like laying out the different scenarios. So, for example, if X, Y, Z compared to A, B, C, D happens, then I want this and this to happen. And going through those different venues and different ways you want to age is something I think that I've talked with my grandparents about, and my parents have talked to them about, and something I think they've come to appreciate too. And so I think specifically in terms of long-term care homes, within that 14 days of your admission, making that plan for your time staying there, your goals of care will be discussed, and that's a great time to, tell your family, discuss with them what you want to happen if X, Y, Z happens. Anything else? Does anyone else want to add anything to the slide?
Yeah, I think you're way ahead of the game with your family, Emma, and maybe Dr. Kerner could comment on that, because I find that it's not as bad. I think it's getting a little better, but still a family struggle with this because they didn't discuss it before as you said, a crisis often precipitates admission to a nursing home, and they never discussed this with their parents, or the parents hadn't discussed it with their substitute decision makers.
Yeah, I think it's important. I think we all learn from the patients around. Being a physician gives you privilege and insight to people who share stories that they'll never share with others. I'll just share two stories of my own parents. Both my parents died of dementing illnesses. My mother did not die as well as my dad. It's a terrible thing to say. My mother has something called progressive supranuclear palsy, which is a dementing illness where you lose the ability to walk and you fall and hurt yourself. She never really accepted that. She never used the devices properly. So she fell, broke things, and always blamed others for her falls and things of that nature. And, there was no cure for this. There was no cure then. There's no cure now. But people around her suffered as well. Where my father died of my dad, both my parents are my heroes. Both my parents gave me the ability to try hard and to always be successful. So my mom was the person in the family in times of crisis. She would find a solution. Where my dad was that individual who explored the world and had 3 full-time jobs and always taught us to always try and not be afraid to fail. So I was very fortunate to have very supportive parents and brought different aspects to that. When my dad became demented, at first I didn't realize he was demented, and that happens most of the time because behavior changes. He drove up to see me, and he can't remember how he got to my place, and he describes a story that he got out of the car in the middle of the highway. Obviously, he didn't get out of the car in the middle of the highway. At least I don't think he did. Where I went on a trip with them when we were able to travel together, and where he'd always want to go home and go to a safer place. At first, I thought it was a behavior problem, but it became apparent 2-3 years later he was developing Alzheimer's dementia. So I really was mad at myself for not recognizing that. In fact, I had to take my dad's driver's license away from him. And that was one of the hardest things I had to do, but was the right thing to do. Driving is a privilege. And so when he went to his long-term care, we were able to afford good things for him. And both the times when my parents in their lives, we were in a fortunate position to provide them extra care. And I think you have to think about in yourselves as well, is that my dad didn't want to be a burden to others, and that was very important. And but as a son and having brothers and sisters, you want to support your parents. So So you need to have these conversations. When do you go to the hospital? Not go to the hospital. When do you recognize things? And spending time. So, at one time, I was in the States and my parents were sick. So how do you go back and forth? Number two is that I'm in Hamilton, they're in Montreal, so getting back and forth. So think about when where you're going to end your lives, how close you can be to family or not, if that's important to you or not. And I think for most of us it is. So think about, where you're going to be locations-wise. And I think it's really important to, if your loved ones don't tell you what they want, ask them. Write it down. Because sometimes I feel people don't know, and that's kind of surprising. One of my goals is to be as productive and as helpful for as long as I can. I don't want to be a burden on other people in the future, so I'm going to put resources, or I have been put resources, so I'll be able to do certain things. But that takes planning for 30 years, to put money, we're going to spend more time in retirement than working years the way things are going. And if you think you're going to plan for retirement, you got to start planning it the day you have your first job, from my perspective, to think about, putting money aside for the future and things of that nature. So medicine is one of those jobs where you delay gratification, so because you're always working for the future, right? Medicine's also a job where it's a privilege to try to make a difference. So my plea to everybody is to think about what you want and how you want to age. My mother-in-law even wrote her own eulogy. She was dying for cancer, but she had a wonderful death, if you want to say it's a wonderful death, but it was a wonderful death. My dad had a very good death. My mom had a lousy death. And left scars that and some of our family members and things of that nature. So how you're going to pass away can either be a celebration of one's life, or it can leave problems. So, for instance, my mom always wanted to go to the Ritz-Carlton. We grew up in a poor environment. We never had to go to the Ritz-Carlton hotel. So we celebrated her life at the Ritz-Carlton, something we couldn't do before. But my dad loved lobster dinner, so we had a lobster feast to celebrate his life. So those are the things to think about. So those are the things that really are very important to find out what's important to people. So just think about how to be healthy for as long as you can, but also is when you're going to be becoming ill and sick, how it's going to impact others and what the best thing should be. And that anyway, each one of us have to make those decisions. Any thoughts from anybody else there? Because you see a lot of these people. I see a lot of these people too as well, and how to make good decisions.
Yeah, I have a thought. Oftentimes, when I meet a resident for the first time, or maybe the second time, I'll ask them if they have any thoughts about their end of life. And it's funny because sometimes they'll just like knock your socks off. They'll say, "Yeah, when my time's up, just let me go." And they will not told anybody that, except when you ask the question. And I guess the time's appropriate, and they just say these things. And they'll often say, "I've lived a good life. I just want to go with dignity." Other ones will say, I'm a religious person. When God wants to take me, he'll just take me and just let me go in peace. So I find sometimes patients do think about it, but maybe they don't talk too much about it until the situation is such and they're asked, somewhat directly about this. What do you find?
Yeah, I find the children would have more trouble with it than the resident, and because it wasn't discussed ahead of time. But if you could, and unfortunately, when we get them in long-term care, a lot of them can't speak for themselves. So we talk about it early in their admission, and try to help them through this, because these are often most of the residents we get, they're near the end of their life. They have limiting illnesses. And so, but to take the burden off the family, hopefully we will all speak to our children, our substitute decision makers, and let our wishes be known. And your wishes, it changes too as your disease progresses, and as your health changes, your wishes change. So it's something in progress. It's not the same. It may be different 6 months from now than it is now, and so we have to respect people's wishes and let them think about what they have, and work with them. But getting them to think about it, it never hurts. The earlier, the better. And you're lucky, Emma, that you brought that. And you're more comfortable. And when you bring it up too, they'll be more comfortable talking about it as time goes on, because they've broken the ice barrier. Death is and dying is very difficult for most of us to. It's something we're all afraid of, especially when we're younger. It's hard for us to discuss it, but I think bringing it up in older people aren't so afraid. So, but their children are afraid. If I bring it up to my children, they say, "Dad, shut up," and they don't want to think about it. But as you bring it up and get them more comfortable, then later on it'll be easier for your parents to talk to your grandparents. And it's something in progress too. It can't be done in one session, and as their health changes. So yeah, that's I just think everybody should think about it from what their wishes are, with what they want the healthcare system to do for them.
One of the things that this pandemic has brought to light is that in the initial phase of the pandemic, people were dying without their families. Now we're bringing that back. And one of the things that I got to experience, because as telemedicine became part of regular medicine, I got to talk to some people every day for the last week or so, or 2 weeks of their lives. It was a really privilege to be in people's families. And you didn't have to, at one time, the doctor would visit the person. Now you can actually use phone calls or other modalities to be involved in that. So we've come a long way about this. One thing I always find in families, there's usually somebody who thinks differently, and how to resolve conflict. So you need to look at your family and decide who's going to be your substitute decision maker if you can't make decisions. Is it going to be one person or a combination of the above? I think for most of the time it's better to have one person if you can, and you as the substitute decision. It's not about what you want; it's what the person you represent wants. So I always say you have to put yourself into that person's body, mind, and what would they want in those times. It's always hard to say goodbye, but what I don't want is people to be, I don't want to lose a loved one, or therefore I'm going to do everything I keep them alive when that person didn't want that. And that's, in one sense, it's very selfish. I understand that. And so we have to live with that person. Some people say, no, under all circumstances, I want to be kept alive at all price. I get that. Other people feel that let me go very peacefully. And most of us want to die at home if we can, with supports and loved ones. And now that's more possible ever than before. It's not always possible. So I don't want to dwell on this, but the decisions you make now and how you share that is really important. Write it down. I haven't done this. I've procrastinated a lot of different things. I want to actually create videos for each of my family members for the future. My dad wrote me a letter, and I still have many years later.
Very nice. Very nice.
Thank you, everyone, for sharing those stories. And so, in the interest of time, we're just going to shift gears a little bit to talk a little bit more about long-term care facilities. So these are just some statistics on the typical residents in the population that makes up long-term care facilities. The average length of stay is around 2 to 2.4 years, and over 50% of the long-term care residents are 85 years and older. and 86% of residents need extensive help with daily activities. 76% have heart and circular diseases, and 64% have diagnosis of dementia. So when we take a look into a typical day as part of a long-term care facility, the care team is made up of many different healthcare workers, different types of healthcare workers with different backgrounds. So we have, registered nurses, personal support workers, therapists, pharmacists, and physicians. And there's going to be 24-hour care, drugs, and prescriptions. And something that I found really interesting that Dr. McGarry shared was that there are many, many mandatory programs that, as part of the long-term care facility, they are required to run as per government mandate and laws. So some of them include, fall prevention and management, pain management, responsive behaviors, etc. And so something that Dr. McGarry really recommended for everyone to take a look at is Andre Picard's new book called Neglected No More. So Andre Picard is a Canadian author and journalist. And in this book, he touches a lot on some of the issues that I know for myself personally, I'm not experiencing. And so that includes, the economics involved in elder care in Canada, current policies, as well as some shortcomings that, that have been around for a long time, that COVID has really brought to light. And we'll talk about some of those shortcomings in the slides later on. Dr. McGarry, would you like to add anything on about Andre Picard?
Well, I think Andre just released his book, I think in the last week or so. So he's been interviewed on different media, the CBC, on the Journal, and the National, I guess, and on the radio. And he had a little introduction how he said, why have we had so many deaths in long-term care in Ontario? Why were there 30 deaths in Quebec from a fire with untrained staff? Why would an elderly woman get locked out of her retirement home on a night that was 20 degrees below zero and freeze to death? And she was the mother of the leader of the opposition in Quebec. These are just a few things that he brings out, and he talked about other jurisdictions in the world, particularly I think the gold standard's Denmark, who spends much less money than we do, but has better outcomes. We're not the worst, but we're not the best, and I'd like to see Canada as the best. And it's not necessarily, he didn't think throwing more money was always the best way. We need better policies. There is some prejudice against elderly people, and they call it ageism. And and in the Medical Post, I don't know if you saw that, Greg. In the last today, wasn't it? Today or yesterday?
Yes.
There was an article about how in society there's good poor and there's bad poor, and the elderly people seem to be the bad poor, and we're just doing what they did in Elizabethan times. If you're the bad poor, you get the poor house and bad treatment. So he doesn't think things have changed in the last 300 or 400 years in our society. But he said we certainly can make changes, but we don't need more studies and commissions, because the studies at the end say the same thing. And I think we need to go and look at what are other people doing better, and we can do better too, and get better outcomes. And it's not necessarily, and I think we should all read summaries, or if you can get it from the library, or I'm going to get the book. It's just been released, and something I think we need to discuss with our politicians, especially in elections coming up. And one thing the pandemic pointed out to me, especially one nursing home, I lost 50% of my residents over Christmas, and from COVID, and there was no help from. There was no help because it wasn't that the other jurisdictions didn't want to try; they just didn't have the resources. The local hospital didn't have the resources. Agencies didn't have the resources. You couldn't bring staff from other facilities. They ran out of oxygenators. They ran out of drugs. It infectious control procedures broke down. And all these things could have been prevented with better training and preparedness. And so we don't want to see this happen again. There'll be more pandemics in the future. And so I think there's going to be a revolution, I really think, in elder care in Canada. And I think this is the time, just like Black Lives Matter, I think elderly people matter. And I think there'll be a real, I'm hoping there'll be a real paradigm shift and we'll see better outcomes. I don't know what others think.
I think it's also up as individuals to take better care of ourselves. You know, one of the messages that you say during this pandemic is isolate, wear masks, but the best message to me is lose weight and exercise safely. And that message is not loud and clear. It's sad that most of us are eating more bad food. It's sad that most of us are drinking more alcohol. It's sad that most of us are waiting for the gyms to open, but you know what? There's lots of things we can all do right now to improve our health. And if they're going to wait for somebody else to do it, there'll be help, but there's only so much help available. I urge people to take some steps to find ways to improve on their health today, because when you get sick, you lose your reserve and you lose it very quickly. There's how do you predict a pandemic? How do you predict these sorts of things? There's always going to be the next disaster that's going to take place right now. But developing more resilience and working at this are important. Yes, there's a lot of bad things that can happen, but there's so much each of us can do right now. And I'm really privileged to learn so much that in the last year or two, and I'm just follow your curiosity, keep working in that direction. And in one sense, I feel very sorry for government because they have so many people. Everybody has their own priority, and they're all great priorities. So it's easy to criticize. So how do we all make ourselves better and things of that nature? So this is a really good reflecting point to look at that. Any thoughts from anybody else?
I have a thought. Just by coincidence, I was invited to a International Women's Day event this afternoon. It was on Zoom, and the topic was resiliency. And you just spoke about resiliency. And you're resilient if you have a downfall or something bad has happened, but you come out of it just as strong or stronger. And I think that's what you're talking about, Dr. Kerner. And I think that my message is particularly to the younger people of this audience, like your students, that they should learn from this pandemic. You know, if I had been at university and had experienced this pandemic, I think it would have given me a broader way to look at this pandemic when it did happen. So I think that we all have to learn from what's happened this pandemic, and particularly for young people, because they're going to be the ones that are going to be around and leading the troops when we have the next pandemic. So I say that, you know, I encourage people to be resilient from this. Be resilient in yourself insofar as doing your exercise, trying to stay healthy, encouraging your neighbor or your friend, come out and walk with me, come out and exercise with me. But even deeper, like you say, you like to keep your brain going and thinking about it. We all have to start thinking, what's this pandemic taught us, and how are we going to prepare for the next?
I could be the devil's advocate then and say, okay, Joanna and Greg, that's great. So I don't need a nursing home when I'm 75, but now you've made it that I'm going to need a nursing home when I'm 95. We still have to have a good place for me to go, and I still want to have fun there. I want to be well cared for, and I want it to be, I don't want to be a burden on my children. And I think you're right, you have to take care of yourselves, but by doing that, my father dropped dead at 67, and maybe I'll live and who knows, develop dementia at 90, 95. What do you say to that, Greg?
I'll be glad to come visit the nursing home at 95. I'm sad to visit the nursing home when you're 67. So we are living longer, and we can live better. And to me, I'm just as curious of the world now than I ever was. And I also feel bad that many of us are a little too selfish and too self-centered. We're looking what's just good for us individuals. We need to look at societal issues. That's from the environment to our next door neighbor and our friends and things of that nature as well. So should one country just vaccinate themselves first? There's some ways of looking at this. So I don't have all the answers, but I'm more curious and more passionate than ever. I never thought I would spend my Friday night on WebEx or YouTube. I didn't really know what the word Zoom was a couple of years ago. I remember growing up, Friday nights, used to watch MASH in the family bedroom on my parents' bed and watch All in the Family. Now Friday nights are spending time on Zoom, WebEx, and YouTube. What a change, and what a great change. Move forwards and there are great people out there doing great things, and we need to make everybody better.
Absolutely. And so that brings us into our next section of after a little bit of self-reflection and talking with other people, asking yourself, is a long-term care facility for me? Do I need one at this point in time? And so one of the questions that I think Dr. Carnew always urges people to really think about is, where do you want to retire? So where do you want to spend, the remaining years of your life? And how long do you think you can realistically stay there? How can you, if you want to retire at home, how can you make sure that your home is compatible with you as you age? And so at the end of the day, the goal is still to stay as healthy for as long as you can. And so these are just some of our many webinars that we've done, and we've had a great group of volunteers working on all of them. So we really urge you to, if you're working on staying active, or if you're trying to cut down on your drinking, you're working on your eating, we have webinars for everything in between, and we would love for you to take a look at them and let us know your thoughts and see what you can learn from them.
So just back one slide there, just to pause there. So what we just started is the 3 M's: mindfulness, meditation, and movement. Jerry, who's leading this with his team of about 10 people, is teaching us how to become more resilient. Devanshi is actually, and so Jerry's team works on Wednesday night, and it's a pleasure joining them. I'm usually walking the Shidok stairs. This week I actually played tennis for the first time indoors, and then this older person, or when I say my age, beat the hell out of me. It was great. I'm still sore today. Prescription renewals. I think Maria and the rest of the team there. You know what? You got to know what's going into your body and what to do about this. Winnie and her nicotine replacement and getting people to stop smoking. This lady is a gem that just talks to people about their tobacco. One time alcohol was good. Alcohol is not good. You can drink alcohol. One time sugar was good. Sugar is basically a derivative of cocaine. What I'm quite impressed is that we can debate what you want to eat, but eat more plants. It's good for the environment, good for the animals, and it's good for your health. How to maximize your appointment time. I'm truly amazed when when Bell or you're going to get something delivered to your home, they don't tell you you're coming at 7:05. They're saying they're going to come that morning. The way my day goes right now is that I'm usually here around 7, and I'm usually here till about 9, 10, 11. Sometimes I don't make it home. I will try to get to most things most times, but I will interrupt to deal with things that are most important at that point in time. And as I expect of myself, and as I expect of any physician or healthcare provider. How to make yourself mentally tough and things of that nature as well. Some days I can't. Some days I fall apart and I apologize. Other days I just come back and start tomorrow next day. So every day is a new beginning. So I'm really proud of everything that everybody's done from Emma and Stuart and so many others. This is a work of 30 years plus, built every year. Everybody makes everybody better. So I can't wait to. So if all goes well, I might join you at the retirement home or the nursing home when I'm 100 years of age. So I would like to retire when I turn 100 and go to the nursing home for the last 6 months of my life and just sit back and maybe have that beer that I'm not going to have now or something. I don't know. But I don't know. And I just and as you point out is that most of us end up in bad situations very quickly. You know, an accident happens, you fall and break your hip. That shortness of breath becomes a flare-up of congestive heart failure. You stop smoking 35 years ago, but 30 years later that COPD finally catches up and takes your life, where unfortunately you get cancer. So something, it will happen, but how you respond to that is something you have to think about. And I am so proud of all these young people here who have done so much to help, and they made a huge difference. It's also a shame that we are leaving our problems to them. We should not do this. I urge all of us is that we need to clean up our act, and we cannot keep pushing the national debt to the next generation. We need to pay our dues, and so my job is to leave something for the next generation, not leave a debt. Leave something for them. So that's one of the things that I personally feel is important. But everybody's different. I'm not saying I'm not trying to impose my wishes. I want people to decide what they want and make sure you share that with the people around you. Let's hear a little bit more.
So the next slide is, again, just to reiterate how to stay out of long-term care homes for as long as possible. So eat well, stay active, prevent falls, and we discussed that in depth previously. Plan for a house that's compatible with your disability or illness, or just you as you age, and work with your doctors to delay health issues. So, of course, we can postpone a lot of chronic diseases, but we can't completely prevent them. But again, a big part of that is still making sure that you're planning ahead to prevent it for as long as possible. So I will pass it over to Stuart, who's going to talk a little bit more about the well-being prescription.
So we've done this several times before in other webinars, but a large focus of our conversation today was on staying healthy and being proactive. You owe it to yourself and you owe it to the people you love. We encourage everyone who's on the webinar right now or who's watching in the future to fill out a Google form, which we have in the description of this video, letting us know what your SMART goals are and how you're hoping to achieve these SMART goals. It can be related to your diet, related to your exercise, related to staying social with the people who you love, and we'd love to hear them. If you would like additional support or you'd like a student to call you as well to help you stay in touch with your goals and help you reach them, we would love to be able to help as well, and we encourage you to let us know by simply sending us an email to drkernu232@gmail.com. But again, if you are interested in sharing your SMART goal with us and you would like us to be involved in your health, we encourage you to do so by filling out a form in the description of this video.
And so to bring it back to long-term care facilities, your choice of going to a long-term care facility is a myriad of decisions and a lot of factors to consider, one of them being health and medical needs. How much care do you need? Can that care be met by your family members, your children at home? Or do you think a nursing home would be better, or do you think you can manage with a retirement home? It also depends a lot on personal circumstances. So do you have children and caregivers in your life that can care for you? How is their situation? Oftentimes they may have to work, and it's very difficult to be a full-time caregiver as well as someone who works 40, 30 hours a week. And this also requires an honest discussion with your healthcare team. So talk to your physicians, talk to Dr. Curnew, and let them know your thoughts, and they will let you know their thoughts and their recommendations and their experience as well. So something important that we wanted to highlight is that you must give consent in order to be admitted to a long-term care home. So there is still a lot of choice in this. And a lot of this goes in terms of personal circumstances and families, they would often feel guilty about, letting a loved one go to a long-term care facility. We should note that it should be noted that your family as well as caregivers will be an active part of the decision-making process, and the health of that individual is part of the long-term care home. And so they, I believe Dr. McGarry mentioned to me that they will be informed by phone call of any changes in health, medical, and well-being in general. Dr. McGarry, did you want to add anything in terms of families and feeling guilty? Dr. Hill as well?
Well, I think it's there's depression and guilt when people are admitted to long-term care. The children feel, or the family feels badly that it's come to that, and quite often the resident didn't want to come, mainly because they don't have the insight into the level of care they required. And we work with the homes are well aware of this and work with families about their guilty feelings. And every family is different, so some can keep their elders there till the end of life. Other families just can't cope. It's not large enough, or they just don't have the resources. Not everybody has the same resources. So main thing that they're social workers. They're non-judgmental. They take individual circumstances into consideration. It's a real adjustment. I can say, though, for most residents, when they get into long-term care, at least in the short term, they often improve, don't they? Because they get the socialization, at least before COVID. They get the proper meals. They're getting, most importantly, their medication on a timely basis, and it's consistent. They're getting proper medical care. They don't have to get to the doctor. The doctor will come to them. And so quite often their chronic diseases can be stabilized. They'll often improve for some time before their diseases progress. Yeah, so
I think there's another factor too, and that is that one of the mandates of the long-term care facility is residents first. So we do things because it's the right thing for the residents. It's not the right thing for the staff or something else. It's the right thing for the residents. And also family now is getting a higher spot on the hierarchy. So like if it's good for the family, it's probably good for the resident. So often we see family and we try to help them overcome guilt. So maybe, a family member is very good doing something for this resident. And we say, well, the resident really enjoys it when you come and read to them, say, for 30 minutes, 2 or 3 times a week. That is, the resident's face just lights up and they enjoy those old stories that you read or whatever. And so we include them to come in and be part of the caring of the resident. And usually it helps family, and plus obviously the residents like it because it's their family giving them special one-on-one attention. So I think that's come a long way. Whereas I know that like 20 years ago, the staff would say, oh no, not that family member again, why they have to keep coming to the home. But we know now that actually by having the family members come in, you improve the communication and everybody feels better about it. And, after all, this family member has known the resident so many more decades than, you've only met the resident at the home for a year or so. And I think the same with hospitals. Like 20 years ago, we weren't so keen on having families come in all the time. But now, most hospitals, when it's not COVID, we have kind of like an open door policy, as long as you don't get too many people in the room. But you know what I mean? Things are changing and changing for the better.
Thank you for sharing those insights. And so another great way, or a quick checklist that we came up for you in terms of picking a long-term care home, include to actually do your research and do your homework in terms of looking up the different government reports there's a lot of information about, the number of falls, the number of hospitalizations, and all of these details that are available on government websites. Take a physical tour, if possible. Of course, with COVID, that's changed a lot. And then I think another important thing is to talk with the residents at that home, gain insight into what their daily lives look like, and understand their culture and their staff. I think Dr. McGarry and Dr. Hill touched a lot on this. Culture, where do you want to grow old? Who do you want to interact with on a day-to-day basis? And I believe these things also apply for retirement homes too. Retirement homes, you can look a little bit more into the programs, the different amenities they offer, and of course, cost is definitely something that one should consider. So make a list of your top 4 and 5 choices. And again, oftentimes it does depend on the home's availability of certain types of care that you may need, as well as just the wait list and the number of people who are also applying to that home. And so for our final section of tonight's webinar, we're going to touch a little bit on the impact of COVID-19 on long-term care homes. So in Ontario, COVID-19 has exposed a lot of the weaknesses that have existed within the system for a long time. You can see over here, this is a graph that I took from a few days ago, I believe late February, and you can see right at the beginning, once COVID around March, April hit, the numbers were, I think that's maximum, over 2,900 over, I believe, maybe a week or a few days. And you can see the trends over time. This is our second wave over here. And some other numbers, 80% of COVID-19 deaths within the first 2 months, as you could see in the spike previously, were long-term care residents. And 2,877 deaths due to COVID-19 in Ontario long-term care facilities. So these numbers are not great. And it exposed a lot of the weaknesses. And Dr. McGarry was kind enough to let me know of his thoughts and some of the weaknesses that exposed. So a lot of it came down to lack of training, education, and funding for infection control procedures, which we all know is critical for COVID-19 care and making sure that no one else gets infected and containment. It has been chronically underfunded. As well, there have been many pre-COVID issues that have existed for a long time, such as staffing and housing issues. And Dr. McGarry, Dr. Hill, would you like to add on anything here?
Well, those are the highlights. I think if people are interested in it, read the Card's book or his highlights. And as I say, there'll be a lot in the press in the next 6 months, a year on what changes we can expect and improvements. I'd like to see more things that they do in Denmark that we can emulate here. They have seniors taking care of seniors. They have housing that doesn't look like nursing homes that are mixed in with regular apartments. They have their costs are way less than ours, yet they have better income. So I think this has been known for years. Better outcomes. They've had this has been going on for years, and we need to look at these other jurisdictions and see what we can do. Canada is different. We're spread out more. We're multicultural, but we could still. There's so much room for improvement, and it's up to you young guys now to straighten the system out in the next 2 years, so that we'll be okay. Yeah. Greg.
So some countries like the people who work in there don't look like doctors and nurses. They dress in just normal street clothes. You look like you're living in a community, not in a home. Having birds, budgies, dogs, cats, having gardening abilities and things of that nature are so important. So there's so many ways of transforming, and one of the things is that having your family around, if possible, as part of the care. Is some countries' medical care is that in some third world countries is that there are not enough doctors and nurses. So what happens is the family washes the floor, cleans the bed, changes linen. So how do you evolve to a situation where it's a shared model of care? I think there's so many opportunities. We are spending a lot of money for so-called nursing home. What was the cost of being in a nursing home per year, Emma?
So it ranges between $1,900 to $2,700 a month.
That's just the room and board. I think the government probably spent
Close to 80,000.
yeah, they probably spend $5,000 or $6,000 a month per resident per month on top of that. So it's billions.
So, we're spending a lot of money and saying we're underfunded. I don't know, where all this money is going to come from. And we're all getting older and sick with more comorbidities. So our current model just doesn't fit. We can't fund what you need. I can't give the patients I look after the care that they need. And I'll never be able to give the care that people need, but I can give parts of it. And so what I'm trying to figure is how we share this better. We talked about lifestyle changes, but we have phenomenally great drugs that we didn't have 30 years ago that extend your life, add quality of life as well. We have to learn how to use them properly. So, but we also have we have to figure out how to put this all together. I don't have all the answers, but I certainly like this evolution of this model here, and so we learn a lot. Any other thoughts from Stuart or Emma at all? Do you have any other thoughts about how we should evolve our long-term care? And one of the messages I'm taking away from here is that the last 2 years of your life will probably be you need care, and you want, and as you point out, is that you want to make that care to be as good as you possibly can, and not to be a burden on other family members, but have your family members welcome to come be part of that when they can, and get rid of the guilt, and get rid of the blame game, and just sort of we need to do a better job. And yes, so my urge is that how do we share responsibilities in some way, and I'd be curious to see how that evolves.
So yeah, that was a wonderful discussion, and thank you so much for everyone's time. So just as a quick summary of everything that we've covered today, we started off getting to know a little bit more about Dr. Hill and Dr. McGarry, as well as Canada. Then we explored a little bit of the 5 different types of care in Ontario, and then specifically took a deeper dive into long-term care homes, deciding whether or not it is for you at this moment, and how COVID-19 has affected long-term care homes, and some of the shortcomings and other interesting concepts that we need to think about moving forward. So some of the main takeaways that we really want to drive home tonight is to plan ahead as much as you can. So we completely understand that, of course, crises are very out of the blue, but if you can get as much planning ahead as you can previous to those things, the better. And to stay as healthy for as long as you can, as well as to talk to your family about your wishes, and these wishes may change over time, and that's completely okay. And to continue to talk to them and have that open conversation with them, and to not be afraid of what the future holds. And so Dr. Curnew has a book recommendation by Atul Gawande called Being Mortal. Dr. Curnew, would you like to touch a little bit more on this?
Well, this is a book I've read and I've forgotten read. So what I want to remember, all of us, we'll forget 80% of what we learn, and that's what makes these webinars so valuable to go back. But this is actually, it sort of blends that experience from the Denmark experience to others as well, and how you can age well and how you can actually look at different perspectives. So I think this is a great book. If anybody else ever read this book, what'd you think of it? We can't hear you.
Yeah, I think it's a great read because it's about this older gentleman and how he declines and how his son perceives this. And at the beginning, the son is quite distant from what's happening to him. But then the son, who happens to be a surgeon, understands what's happening, and his dad is getting weaker, and and he looks at this process in a very humanizing way, and I think it's a great read for all of us that want to make a difference to the elderly.
And one of the parts where they they put plants in people's rooms and brought birds into the retirement setting, or had put a garden in certain places as well, and how that made a difference. So I think, Emma, when you point out at the beginning is, look around. So my advice to everybody is look where you live right now, and look what's important to you, from your favorite chair to what's important to you. If you love sunrises, try to get a room where the sun rises. I think we all want to be close as we can to our families, not be burdens on our families. But I think it's really important to think about this. And again, I feel tremendously sorry for the government, because there's so many perspectives and everybody has their way of looking at it. So I want people to come from a position of, make your wishes known. Realize that we will need care at some point in time. And when I hear statements, I will never end up or put my dad or mom in a nursing home, that can actually change. Or promise. I had patients say they promised their parent that they would never let them go in a nursing home. Well, if you read this book, Being Mortal, there are some wonderful places that you can in your life, and you can make it more like a Disney World cruise. And maybe Disney should take over the nursing home industry and see how they can transform that in some way, because as my wife says, I live in Disney World. It's a good place to be most of the time. And so how do you bring that to the reality of today's environment? Wonderful talk, wonderful discussions, and thank you all for doing that. And any thoughts from anybody else?
I believe that brings us to the end of this webinar and the end of this talk. Like Dr. Kernia said, thank you everyone so much for your time, and thank you especially to Dr. Hill and Dr. McGarry for your time today and your wonderful discussion points. Stuart, any closing words or anything else?
I think that was great, and it was an honor to be involved. And Emma, you did a marvelous job, and I thank you so much.
I thank you all. I think I first met Philip and Joanne at a traditional medical conference. Since then, our relationships have grown. The science is the easy part. The emotional part is always hard to deal with. But as they get older, some days the emotions are more important than the science, and some days the science are more important than the emotions, and how to blend that well. We are all going to get older. We are going to get frail. Remember that slide? We start off at 1. At some point in time, we're going to be a 9, and maybe we can move up or down part of that way. And thank you all for sharing. Stuart, I'll give you the last word. Stuart is one of those guys that just makes things happen week after week, and I don't know how you do it, but thank you.
All the credit to Joanna, Philip, and Emma for the great seminar today. We did have a question, and I'd love to bring that up at this time. One comment that was left in the comments was, last 2 years of one's life will all need care in a nursing home. Their question is, when does one know when it is the last 2 years?
We don't. Medical people can make predictions. Most of us want to end our life suddenly, not wake up in our sleep one day after a fulfilling life. We now have the ability in many conditions now to decide when our lives are going to end right now. Let me decide. But the reality, when it comes to heart disease, congestive heart failure, you look like you can die one day and then you're around for, you're better again. And so we can give our best predictions, but we're not that accurate. And I can tell when you're very, very close. But the problem is that usually it's some sort of catastrophic event that takes place. And it can be triggered by a simple fall, breaking your hip. You're able to do those 4 or 5 minutes on a good day. Then you get sick, you're down to 3 meds, and you can never go home again. So I wish I knew how to do that better. I can just stack the odds in your favor. I'd be curious to see what Phil and Joanne have to say about this being long-term physicians. I'm always surprised every day of my life.
Yeah, we agree with that wholeheartedly. Sometimes the families will say, well, how long does mom and dad have? Sometimes I'll say, well, by spring, I wouldn't be surprised if they're gone. I can't be 100% sure, but that's often the way I say it, and it's variable, so variable. But even in the nursing home, you can take care of yourself. You eat properly, try to get your exercise, participate in activities that they have. You can even live longer and be happier in a nursing home and continue what Dr. Kurnu has taught us. You can continue that in a nursing home in long-term care. Or you can just be a recluse in your room and smoke and still drink and have a short time in a nursing home. So there's a continuum. Depends on your attitude, the love of your family, your social interactions. So that you can continue your longevity even in a nursing home and be happy. So what do you think, Joanna?
Yeah, I think we just don't know. Don't know.
But I can give some good predictions. If you have an ejection fraction of 20% or less, your 1 year mortality is 50%. The day I make a diagnosis of congestive heart failure, 50-50 chance of being around in 5 years. Going for a coronary angiogram, a 1 in 1,000 risk that you're going to die. Having a stress test, 1 in 10,000 risk you're going to drop dead. I can go on and those sorts of things. Those are numbers, and we all say we're not a number, we're an individual. So I think we have some appreciation of this, but we also have a lot of uncertainties. But the best thing I can say is that I'm going to end is that I think it's called the Harvard Longevity Study. And the number one predictor of how long you're going to live is the quality of relationships and the amount of those that you have. So that's very important. And I think we're starting to understand the social aspect of things better. But you know what? When I say you have a 1 year mortality of 50%, I now have in systolic dysfunction, I can give you 5 drugs that can give you years of quality of life left as well. And that's something I couldn't do 10 years ago. So it's remarkable. Who would have thought we have successful vaccines in COVID in less than a year to 2 years? Holy Moses, the world has changed. So we have better science and we have better understanding. So we can do so much more. And by the way, trust the experts around you. If you think you know more than the experts, good for you. I look for experts in all fields. I can't fix a flat tire. I can't fix my TV. I can't get the internet to work most days. But I know quite a bit about the cardiovascular system, and I'll be glad to share that with you. And I also have an opinion about just about anything.